Brian actually gave excellent talk about how we use the genetic information for prostate cancer care from bottom, screen, and to the top. And he gave a perfect kind of interpretation from a urologist perspective. And I will use the next couple minutes and give my interpretation from a genetics perspective, how genetic information involved in the pyramid, particularly at the bottom. So I will focus more on prostate cancer risk, maybe a little bit on the prognosis, but particularly on the prostate cancer risk. So here is my disclosure, actually not short, where I work with has a agreement with GoPass offering polygenic risk score test. For me, polygenic risk score is amazing. We started this whole thing 2008, the first paper published in New England Journal, if someone can remember that. It's a combination of Wake Forest, that's where I worked before, and with Clem Cater, I don't know if Clem Cater is here or not. Great, with Cater. And then Hopkins and the Karolinska, 3 groups worked together to demonstrate from the first 5 risk associated to show polygenic risk score can be used to stratify the risk. And we really had a difficult time in the last 14 years to actually sell this idea and to implement in the clinical setting. But if you are here today, yesterday, and there's so much talking about the polygenic risk score, so this is really good. So I'm going to talk about really 5 very simple things. First is who is really at elevated risk for prostate cancer, who is at risk. And then what is the relationship of 3 inherited risk factors: family history, monogenic gene, polygenic gene. Can both monogenic and polygenic tests implement at the same time? And then I will spend a little bit of time talk about the challenge, even though we made great progress in the last couple of years, particularly last couple of years, but we still face challenge. And the last thing is to talk about how we can use the available science to push the guideline to integrate well-established evidence into clinical guideline. So who is at risk for prostate cancer? And we are familiar with the NCCN guideline for early prostate cancer detection. And if you're familiar with this, and this box for the risk assessment. And clearly, I just make it bigger here. So family history, monogenic gene, family history, and personal history of monogenic mutation. And then African American ancestry. What's missing is potential we talked about yesterday and today is a genetic risk score. So what are those relationships with those 3 inherited risk factors? So family history, as everyone aware, is very commonly used and recommended by the guideline, as we see the guideline. So, but the problem is it's risk. If you have a positive family history, you're at high risk. But at what risk, you don't really know. And previous estimate 2.5-fold and 3-fold, those are overestimate. That's a very typical thing. When you ascertain strong family history, you give a overestimate the effect. The second is relatively new, but it's already incorporated into the guideline for early detection as well as for prostate cancer. So it's reasonable, but like Brian mentioned, it's very rare. On average, if you put all those monogenic genes together in the population, is about 2% of people have mutation. And in the prostate cancer patient, it's not that much either. The last one is what Brian just explained, it's polygenic risk score. So genetic risk score is a particular type of polygenic risk score. We call the population standardized polygenic risk score. The difference, the performance is the same. The difference is it's easy to interpret, like Brian mentioned. If each individual, if you get 1, and you get your risk is equal to the population average. If the score is 1.5, that's 50% increased risk. So it's very easy. So for implementation, it has to be easy. So, and this is something different than what Brian kind of introduced about the performance. And this is based on large UK biobank with over 200,000 men. It's a prospective study. At the time of recruitment, we removed individual with prostate cancer, so they're called prostate cancer free. And then follow about 10, 12 years. And then we assess at the baseline, family history, monogenic gene, and the genetic risk, how those predict development of prostate cancer, as well as development dying from prostate cancer. So the blue line here is the incidence for prostate cancer for 3 risk factors: family history, monogenic gene we call rare pathogenic mutation, as well as genetic risk score. The blue line is the incidence, and the red line is dying of prostate cancer. So as you can see, family history increased risk for incidence, but not really for dying of prostate cancer. Okay, because our interpretation is you identify many individuals at early stage or indolent prostate cancer. Rare pathogenic mutation does increase risk for incidence as well as for mortality, prostate cancer specific deaths, although it's not significant because the sample size is small. And the genetic risk score, you can see, if you have a genetic risk score over than 1.5, I told you that's 50% increased risk compared to general population. Your risk, you have increased risk for incidence as well as dying of prostate cancer. Again, this large population-based prospective study, okay? And you can see the star on top, so it's significant. And you can see greater than 1.5, their effect size is about similar to family history, is slightly lower than monogenic gene. But if you look at individual greater than 3, genetic risk of 3, that's 300% increased risk. And it's about 3.7% in the population. And you can see their incidence and mortality is equal or higher than monogenic gene. But if you greater than 5, we do see those patients through our tests. And it's about 1% in the population. Their risk is way, way high. Their risk is higher than monogenic gene. So if we have a mutation in the things, in BRCA2, we worry. But actually, if you have a high genetic risk score, you should worry also. And here is the report of our genetic testing. We actually report both monogenic gene, genetic risk score, for example, this patient 2.1. We also report monogenic gene. And so you can use those two pieces of information to figure out your true genetic risk for prostate cancer. And as Brian actually showing the similar slide, but here is another example. So if you are BRCA2 mutation carrier, but if you have a very low genetic risk score, your risk is only 9% by the age 85. So even your BRCA2, but if you have a low genetic risk score, your risk is pretty low, slightly higher than average. But if you are BRCA carrier, and if you have a high genetic risk score, and your risk is 56%. So here clearly see monogenic and polygenic actually independent complement. And here I will spend just 1 minute to talk about the challenge for monogenic as well as for polygenic. For the monogenic, as Brian mentioned earlier, we know mutation in monogenic gene increase risk for prostate cancer. But which gene, mutation in which gene increase risk, we don't really know. Only a subset at this stage have evidence. So that's something important to remember. And for genetic risk score, I think the key things, there's 2 things actually we did not talk about in the entire Brian's talk. So the key thing about genetic risk score is the reliability of the genetic risk score you give to patient. When I say it's 1.5, how do you know it's 1.5? You really cannot figure it out from your patient. You have to figure out from large database. That's number 1. Number 2 is ratio, minority ratio. Right now, we only do this for Caucasian, primarily, like the UK Biobank. But we cannot limit our tests to Caucasian only. We have to make them available for racial minority. So this is unpublished data, and we work with 23andMe, and in a large sample size, those are 888,000 white and 81,000 Hispanic. and the African American and the East Asian to demonstrate it's working. So finally, I was probably just 1 minute, talk about, I think you already see the evidence. What we want to suggest is with those evidence from multiple piece, large cohort, prospective cohort, I think there's strong evidence suggests genetic risk score can be used to differentiate risk. So it should be incorporated into the NCCN guideline. So this NCCN guideline, I wish there would be one line here, including polygenic risk score. So basically, I talk about those things. Who is at risk? What's the relationship between family history, monogenic and polygenic? And can they both be tested at the same time? And what are the challenges? And finally, for the implementation, for the NCCN guideline. Here are the individual contribute primarily to the work for the last 10, 14 years on the polygenic risk score, including Brian here. Thank you.